So this is part of a debate on the management of hormone-sensitive prostate cancer, and the controversial thing here is whether you give docetaxel on top of androgen receptor targeting drugs. So the underlying literature is that if you start from a hormone therapy, androgen deprivation therapy alone, we know that adding docetaxel improves survival. We also know that adding a whole range of different androgen targeting therapies also improves survival. And once those two things were established, trials were set up where androgen receptor targeting agents were added on top of docetaxel, and most, but not all of those trials show a survival advantage to adding androgen receptor targeting on top of docetaxel. The problem with these trials is that nobody has done the trial the other way around of adding docetaxel on top of androgen receptor targeting. And you might think it's kind of obvious you'd get the same result, but it's not really, because firstly, the time to progression is much, much longer if you just give an androgen receptor targeting agent than if you give docetaxel. And so it then gets much harder to measure if you get an additional improvement if you add docetaxel on top of an already long time to progression. And the second thing is that not all patients get an entirely smooth ride with docetaxel. The quality of life penalty is substantial. And when we looked at this in STAMPEDE, for example, we had a simultaneous cohort where some got docetaxel, some got abiraterone, and the quality of life was much better with abiraterone. So one of the things we do know for sure is that if you give both, your side effects are going to be dominated by the docetaxel side effects. So we've got a kind of a mixed, muddled picture. And as far as I'm aware, nobody's planning a trial where we're going to look at adding docetaxel on top of any of the AR targeting agents. So that's going to remain probably a permanent hole in the literature. So one of the things I'm going to focus on in my talk is how we might get some data on it through what are called network meta-analyses, where you try and compare, in this case, ADT, docetaxel, AR targeted therapies with either ADT, docetaxel, or ADT, AR targeted therapies through an indirect comparator, usually ADT alone. And quite a number of these have been published. But they all broadly, to be honest, have the same conclusion, which is that if there is a benefit from the triple therapy, it's relatively modest. But also they fairly consistently conclude that triple therapy is probably going to be better than doublet therapy with an AR-targeted therapy alone. The second way I'm going to look at this is looking at the docetaxel versus docetaxel, ADT plus docetaxel versus ADT alone literature, because it's very clear that not all patients benefit from docetaxel. In essence, the patients who benefit the most are patients with synchronous high-volume metastatic disease, probably patients with high-volume metachronous metastatic disease, that's to say they previously had surgery or radiotherapy and then relapsed later, probably also benefit. But patients with low-volume disease probably don't benefit at all. And in particular, patients with low-volume metachronous disease, i.e. late low-volume metastases, may even be harmed by docetaxel. So I think what I'm going to conclude is that if you should give it to anybody, you should give it to patients with synchronous or metachronous high-volume disease, but you need to factor in other factors, clearly, like fitness for chemotherapy and the quality of life impacts. So it's something that needs to be discussed on an individual patient basis.